Welcome, friends, to Faith in Healthcare. You know, across America, rural hospitals are disappearing at an alarming rate. Financial pressures, physician shortages, and rising demands have left many communities at risk of losing access to essential healthcare. Yet for Christian healthcare professionals, this crisis also presents an opportunity to serve where the need is greatest. In this episode, I'm joined by Mr. Ben Anderson. He's a longtime rural healthcare leader who has spent much of his career helping struggling hospitals not just survive, but thrive through innovative leadership, through mission-driven physician recruitment, and a deep commitment to underserved communities. We're going to talk about what's at stake for rural healthcare, innovative approaches to strengthening rural hospitals, and how Christian physicians and healthcare leaders can make a lasting impact in communities that are too often overlooked. So let's dive in. Well, a couple of months ago, our Faith in Healthcare producer, Miss Kat Denton, brought to my attention an article on Reuters news service about the crisis for so many rural hospitals and clinics across America. And she said, Mike, I think we ought to have a conversation. This seems really important right now. So do you know anybody in this space that could come and talk to us with great insight? And immediately I thought of one of the founders of our specialty section, the Christian Healthcare Executive Collaborative, and that is Mr. Ben Anderson. And so today, Ben is with me all the way from Hutchinson Regional Healthcare System in Kansas. Welcome, Ben.
Thank you for having me, Dr. Jeff. It's a pleasure to be here.
A little bit about Ben before we get going. He there at Hutchinson Regional Healthcare System is responsible for management, direction, and coordination of all organizational operations. And before moving to Hutchinson, was in Colorado as part of a rural healthcare association as a vice president there. And before that, actually, when I met Ben, he was at Kearney County Hospital in Lacon, Kansas, as the CEO, and had all sorts of news articles written about him because of a very innovative, visionary approach to recruiting healthcare professionals to one of the most rural areas in America, because he matched mission-driven doctors who cared about missions, even overseas missions, and this service to so many different nationalities. He was just talking to me about the world's largest meat packing plant, and that drew workers from all over the place, different nationalities. And so I'm talking today to Ben, a very creative, visionary leader, Ben Anderson. So Ben, you're in Kansas, where you told me the other day by phone, a lot of hospital systems are in trouble. Tell us a little bit about that.
Yeah, Kansas leads the country in hospitals in immediate risk of closure. It's somewhere in the mid-40s as far as the number of hospitals that are at risk of closure. Somewhere in the neighborhood of 70-80% are operating at a negative operating margin. And most of them are subsidized in some way by local tax appropriations or property taxes, sales taxes, something like that at the local level to offset the losses. But we are to the point in Kansas where many of those rural communities can no longer tax their local population to offset the growing cost of healthcare and the losses that we're running. And so it places Kansas in a pretty vulnerable place. As a state and as a healthcare delivery system.
It's not the only state in that situation. The article entitled Fragile Economies at the Heart of Rural Hospitals lists so many, but many of them in what some people would call flyover states in America. But why in particular Kansas? Why do you think Kansas is at the top of that list that you don't want to be at the top of?
So we have gaps in health insurance coverage. I spent the first 11 years of my life as a hospital CEO anyway, in Southwest Kansas, and in one of those areas that was one you mentioned, which is Lacon, Kansas, and we were subsidized, if you will, or part of our payer mix rather was a large number of Blue Cross insured folks there, and so we were able to to make ends meet, if you will, because we had an unusual situation in a large number of privately insured immigrants and refugees that were working at a Tyson beef packing plant. But most of the hospitals around us didn't have the benefit of that, and so they had, were trying to maintain a hospital and a local skilled nursing home facility, uh, and uh, and so we hadn't expanded Medicaid in this state, and so we had this 10 or 15% of our population that was uninsured, and so they were using our ER as their only access point. So I moved to Colorado, in a state that had expanded Medicaid. And again, this is apolitical to me. It's not, whether we should or shouldn't or whatever. But I was in a state that didn't and then did, and Colorado hospitals didn't have the same, rural Colorado hospitals didn't have the same financial challenges because we didn't have an uninsured population that we were subsidizing through the emergency department. And because we have not been innovative enough in our system to find ways for employed people to maintain insurance, a lot of the employed folks still are uninsured and therefore are using the most expensive form of healthcare that we've got. So I saw that in Colorado. We didn't have the same financial challenges in Colorado as we do in Kansas. Then came back to Kansas 2.5 years ago, and then abruptly walked back into the place where the decline had progressed, and we're seeing hospitals that are more and more vulnerable to closure here. But there is an insurance gap that exists, and so we're trying to subsidize that through local taxes. So we either tax ourselves at a federal level or we tax ourselves at a local level, but in some way we have to figure out how to care for the old and the poor. And as Christians, we know, well, that's the foundation of our belief system, is to care for the vulnerable. But it's difficult when you mix that with government, and it's a thorny, difficult issue, and there are different philosophies on how to get there. But we've got to figure out how to care for the old and the poor in an organized way that does not include the emergency room as the primary access point.
I think what surprised me a great deal, shouldn't have, but it did, as I began to read the article that was brought to my attention and others about rural hospitals, how much they have in common with mission hospitals like the one that I worked in for so many years. And I suppose many of our listeners are not familiar with the challenges that a critical access hospital in rural America faces. Why don't you tell our listeners just a little bit, help us understand how deeply these hospitals matter to their communities?
They are often the largest employer, Dr. Chubb. They almost always the largest employer, the second largest employer being the school system. And without a hospital and a school, the town dies. And so it starts when a rural hospital cancels its women's health program, or OB, and they quit delivering babies. Well, then young families that are seeking that care go elsewhere, and they stay with the person or the health system that delivered their baby. And so we start seeing the decline there when they shut down OB. But without those systems, the community craters. And so they are largely subsidized right now, and in fact, widely subsidized by Medicare money through what's called a critical access hospital program, which will reimburse rural hospitals at their cost for caring for Medicare patients. And 80-90% of their patients will be Medicare recipients. And so that's really how they're being subsidized at this point, is through this increased Medicare funding, and then also through what's called a rural health clinic, which most critical access hospitals have attached provider-based rural health clinics, and where an urban clinic would get maybe $50 per encounter for a Medicare patient, to see a Medicare patient in the outpatient setting, a rural health clinic may get $200 or more dollars per Medicare encounter, and where they may get $39-40 per Medicaid encounter in an urban center at a private clinic, you might see up to $400 per encounter with a Medicaid patient on Medicaid in a rural health clinic. And so they're subsidizing these clinics with increased rates, and even then, with the low volumes out there, it's difficult to manage.
Give us a little background. I'm just curious, you've got an MBA out in the Northeast, and what has drawn you basically throughout your career to be a leader, a faithful leader in these rural systems, association or hospitals? Tell us what motivated you to be in this place you are right now.
Well, there's two answers to that, Dr. Chubb. One is what I'm doing, and two is where I'm doing it. And in the first, what I'm doing, I grew up very poor. And for 10 years of my life or so, I was uninsured. And I really didn't even realize in those early years how vulnerable I was, because had I gotten cancer, Dr. Chep, I'd be dead.
Mm.
Had I gotten seriously injured, it would have destroyed our family financially, because we just didn't have the resources to access care. But I didn't happen to need care, in my teen years and into my early 20s. And so until I graduated from college. And so we were pretty poor, and I'd always promised the Lord, if I could ever get out of that situation, if I could ever end up with an education or in a position of influence, I'd spend the rest of my life sending the elevator back down. And so God's been faithful in that way. I'm now the president of a health system. I trained at Dartmouth College, got a degree in healthcare delivery science from there, and a lot of that involved breaks I didn't earn, but we're gifted. I think there's providence involved for sure. And so with that comes a great sense of responsibility for me. So I've always felt more called to helping elevate or lift up the well-being or economy within a community. And if I have to run a hospital, then let's run a really good hospital, because to have any credibility to do the former work, you have to run a really good hospital to have the credibility to doing that. And I found that a hospital CEO is as good a seat to do that. It could be the mayor, it could be the superintendent of schools, it could be a pastor, it could be any number of roles. But I just found that this one makes sense to me. And so I've always wanted to do that. And so I went through steps to get there. But the reason we live in Kansas is 5'1" and she's beautiful. And she is like a homing pigeon coming back to the rectangular state in the middle. And she always wanted to live here, and I always wanted to live with her. And so Kansas works well because she really wants to be here. And I've fallen in love with Kansas over the years. We've been here most of our married life, and so this month is our 18th anniversary, and 15 or 14 of those 18 years we've lived here in Kansas together. So certainly love doing the work.
And you and Kayla have raised up 4 beautiful children. I hope I'm pronouncing that right. Kayla, correct?
Yes.
Yeah.
That's right.
So just briefly for our listeners, because I know the story, but I want them to hear about this incredible innovation in Lakin, Kansas, because it had really a significant impact upon international missions.
Yeah, we got there. So it really started out in a town called Ashland, Kansas, Mike. And the town had no doctor and had no CEO when I arrived there. And so the facilities were 55 years old. The finances were upside down. No doctor, no CEO. Morale's low. Turnover's high. Rolling pennies to pay the gas bill, so to speak. Holding accounts payable to make payroll, literally. And so we had to do something there. And so I went to a mission-driven a physician named Todd Stevens, who's a faculty member still at Via Christi's Family Medicine Residency in Wichita, Kansas, as part of the KU School of Medicine. He was from the county where I was living, and just said, "Hey, what do we have to do to get one of your residents to come out here and practice?" And he said, "Well, you'll get 2 or you'll get none. You won't get 1, because we're training them not to go anywhere alone, but always to go in pairs." And it was an international missions model that you don't go out as a lone ranger, you go as a team. And he was a very mission-driven, believing physician. He gave the Lord his 30s when he got out of medical school and residency, and served in Kibagora, Rwanda, Kibagora District Hospital in Rwanda, and practiced full scope family medicine there. And he really mentored me into this work. And he just said, if you really are serious about them, coming, you need to recruit 2. And I said, "Well, how do I afford that in a town of 900? And he said, "Figure it out." Because you won't get 1. You're going to have to, I'm not the CEO, you're the CEO, figure it out. But then he said, if you really are serious, then you recruit 2, you give them 4-day work weeks in the clinic, you give them no more than 1 night a week on call, no more than a weekend a month in a low volume setting. He said, make sure that they have a mentor, even if that mentor is not local. Make sure they have access to a mentor that can mentor them into practice. And then give them 8 to 10 weeks of paid time off to do international mission work. And I thought, all right, wow. I said, I think impulsively, I'm in. And he said, "Are you serious?" And I said, "Yeah." He said, "Then go to Africa with them." I'd never been overseas in my life. And I said, "Whoa, this just got real." I looked at my wife, and she's like, "What did you just sign us up for?" And ultimately, 6 months later, we ended up with a half a dozen shots in our arm, my wife and I, and we ended up going to Zimbabwe to build screens on the windows of missionary housing at Karanda Mission Hospital in Karanda, Zimbabwe, where these international fellows were training as part of a Teams model or a Teams mission model there. And they needed something to keep the mambas and the cobra snakes and the malaria-ridden mosquitoes out of the missionary housing because it was 100 degrees at night when they were sleeping, and there's no electricity, so there was no fans that could run, and so it was a challenge there. And so and of course, every one of the 56 windows is built in a different size, never anything efficient, right? So we had to go do that. But the 2 weeks we spent doing that transformed my life because I realized, as you said on this interview, that we have in rural Kansas have more in common with rural Zimbabwe than we do with Boston, Massachusetts. That a lot of the same challenges exist around housing and health disparities and transportation but we have safety nets here that they don't have. The Medicare critical access model is a safety net model. Imperfect as it may be, it's a safety net model, and they don't have that. People are paying with chickens. I mean, they're paying with goats or with the sadza cornmeal that they make. I mean, they're paying with what they have, and they have to figure out how to make that work. And so, far more efficient in some ways than we are, and in some ways, the American system is more efficient. And so, learned a lot that we could bring back here through just some reverse engineering, and then brought that back and said, okay, well, I guess we're going to recruit doctors that way, and we just began designing a model using a pro forma, using some business intelligence to say, all right, what are we paying in locums fees? What are we paying in salaries? And what are we paying temporary folks to come in here? And how do we design this in such a way collaboratively? So maybe one of our two doctors works in a neighboring clinic somewhere else to be able to subsidize salary. How do we set it up? And we ended up doing that and recruited 5 providers into that community, and then moved on to Lakin, where they really needed about 15 providers to serve a region of 20 or 30,000 people. And so we just recruited in that same way. But once we got momentum around it, and we took a look at the motivations of physicians that work there or they're willing to work there, then the momentum built, and we actually were receiving more requests from doctors that wanted to work there than we could even hire. And so we helped folks helped our neighbors recruit the same way into the region, and ended up with about 30 or 40 medical providers in Southwest Kansas covering several 40, 50, 60,000 people, primary care access for them.
Have other systems caught the vision? Has that been reproducible?
I think so. I can think of some across the country that are doing this, that really are willing to recruit this way. One that comes to mind is in Del Norte, Colorado. Arlene Harms is a believer. She's really, really good CEO and led a pretty significant turnaround there. Has been there for a long time. She definitely recruits that way. Her chief medical officer, also a Dartmouth grad, is Heidi Helgeson, is a family physician and chief medical officer there. They are willing to customize experiences that would allow for this type of work there. Certainly accommodating the healthy integration of faith and medicine. Of course, it can be done well and it can be done poorly, but integrating faith and medicine in that location. Yeah, I can think of some across the country, Midwest and on the coast, that really are intentional about this.
Yeah. You mentioned Todd Stevens. I don't know if you remember, a very good friend of mine, my first neighbor at Tenwick Hospital over the course of 3 years. And Todd is also our Wichita CMDA area director. So very grateful for the influence that he's had on your life and healthcare system, as well as my own life.
He definitely is influential to me. He taught me really early on that the job of a CEO, the role of a health system president, is to help doctors help other people. That's the function. If you're not effective doing that, what good are you? Like, move out of the way. Because medicine started with physicians, and then when it became so complex administratively that it was tying down physicians' time, and we realized we needed people that could take that burden off of physicians so they could continue to practice medicine. And it's become backwards in recent years. And what we've gotten to is now a situation where administrators tell doctors what to do. I have no business practicing medicine without a license. I have no business telling a doctor how to practice medicine. But what we can do is develop a trusting relationship where they know what I'm working with, I know what they're working with, the challenges they're facing, because the system, Mike, pits us against each other. The doctor, has to figure out how to provide care to vulnerable people and I, the president or the CEO, the administrator, have to figure out how to pay for it. And invariably, because of how perverse our system is and how many takers that are part of the system, whether they be consultants or they be vendors or they be pharmaceutical companies or whatever, like we have so much of this money outside of the general care delivery system. The money's not in the right places to get it where it needs to go. So it comes down to physicians and administrators with shared values who choose to walk into trust with each other and say, I'm going to choose to trust you, even though the system tells me I shouldn't, even though my faculty tell me, even though my mentors, even though my CEO could, all those may not tell me that that's wise. I'm choosing to step into a space where I'm going to trust you and you're going to trust me. We have to go there. And that's what Todd taught me.
So tell us a little bit about the kinds of healthcare professionals that are willing to take those risks and assume that trust that you're talking about, and that thrive in these environments, and the factors that determine whether someone's going to grow and thrive there long term, whether it's the current system you're in or Lakin in the past or in those rural hospital systems in Colorado that you experienced.
Yeah, in 15, 20 years, almost 20 years of recruitment, I found 6 common profiles of doctors that will be willing to live and work in hard places. And one is the local kid coming home. If you find that one, happy holidays, Merry Christmas. You found a local kid that's trained exactly as you need him to come home. And they've already have a support system built in. It's great. Often really good fit, but we don't have enough of those doctors being trained in the places that are needed most to be able to meet that. And there are a lot of reasons for that, but we just don't. We're not producing those doctors. 2 is this one's the H-1B work visa doctor that here for 3 to 5 years, generally don't want to be the only one speaking Arabic in the rural Midwest. And so they'll come for their 3 to 5 years until they get that coveted green card, at which point, they're out. They want to move to where their kid can be in a really specific, preschool, or they can be a part of a cultural community that mirrors their own. Sometimes providing great care. Sometimes, if you're from, for example, a Middle Eastern culture that treats farmers like third-rate people, you're probably not going to do well in a farming community. There's going to be an adjustment there. So that's the second kind. The third one's the troublemaker. This one cuts up goats in the front yard, or drinks a mysterious red potion, slurs his words, or has an in-and-out service for high school kids, or throws instruments at people, sleeps with the nurses, yells F-bombs. I mean, no one knows any of them, of course, right? But if you get on the Kansas State Board of Healing Arts, there's some doozy stories on, when you look at what's been reported, even in the state of Kansas. And I'm very sure that Kansas is not alone in that. That there are other places, but a lot of times it's the only ologist, so to speak. Like, I'll go out there and be alone. I'll be the only one because you really need me. You'll put up with my thingy, my revolving door of work-based relationships, or whatever the challenge is. And so there's plenty of them, but they generally wreak havoc. Then there's the money doctor. If you pay me $1.2 million, I'll go anywhere until somebody pays me $1,201,000, or just a little bit more. And generally, rural or frontier healthcare delivery systems can't sustain that, right? That kind of, there's not enough money in the system to be able to pay them to do that. There's the coaster. That's the 5th kind. The coaster, which is, I'm done working, but I'm not done getting paid. I was on call 12 straight years in the 90s, and I've done my time. And now it's these young guys that have to do the 12 straight years. I'm just coming to do outpatient care only, and either dump on my partners, or you can get locums to cover mine, to my ER shifts, because I'm done being on call, but maybe bought too many Harleys, or went through some, didn't plan enough or whatever, but they need to still work into their 60s and 70s. And so they're coasting. And then the last one is the missionary, the one that's driven by a sense of mission or purpose that's greater than themselves. The greater the need, the more they're drawn there. They're your members, Dr. Chubb. They're CMDA's membership. And they actually believe what they said in their med school interviews. And the system hasn't beaten it out of them. They still believe and the great commandment to love God, love our neighbor. And they still believe it can be done through medicine. And they are fighting like heck to stay in the fight, stay in the battle, and care for the least of these among us. And that's the one we determine we're going to set up systems whereby they can thrive. And that's been a life mission for me professionally, is to create systems that would prevent doctors from burning out, from moral injury. And because it is systems that are doing to these doctors. It's not a good or bad doctor or a good doctor on a bad day. These mistakes are happening, or the damage is happening because of systems that are designed to get that outcome. And we've been focused on redesigning those systems and using improvement science to do it.
Well, just like I care about those who are considering overseas missions in Africa or Asia or wherever, wanting them to thrive, you want Christian healthcare professionals like you've just described, our members and constituents who haven't had the system beat it out of them. You want them to thrive. So tell us, what advice do you give to Christian healthcare professionals, physicians, PAs, NPs, dentists, the whole gamut, when they're considering moving to a rural hospital system, whether it's Kansas or another state? What should they be looking out for? And then tell us a little bit. You told me before a few weeks ago about an APGAR system like that you use to for those listening to assess a system.
Yeah, I would say advice first. I go back to, I was at Global Health Missions Conference in Louisville and doing a talk there, and a missionary doctor approached me afterward, and he said, I think it makes sense that we got to get administrators into these places that know what they're doing. I've always said we need to find the kids that excuse me, that didn't get into medical school, teach them some business classes so they can help run our hospitals. And I said to him, just very frankly, is that how you want running your healthcare delivery system and preventing the burnout of the medical staff, or the one that didn't get into medical school? Or do we want the best and brightest, the ones that were student body president, and the ones that are just natural, gifted, God-gifted leaders into these spaces? And do we want them to get the best training in the world, so to go in and design systems so that they can work alongside, not only protect from burnout, but work alongside as administrative dyad partners to develop systems that really can transform the health of communities? Wouldn't you want people with Masters of Public Health training, MBA training, the most elite training in the world running these systems?
And I hope that was a big aha moment for him at that time.
I don't know, but it was an aha moment for me, because I'd never really verbalized that, because I've never heard somebody say, well, why don't we get the kid that didn't get into medical school and have him run the hospital? But that I think is an old school mentality. So I think to the new medical providers that are coming out of training, you don't have to view a CEO as the enemy. And CEOs are a rough bunch. They get their reputation for a reason. And so I think you got to look for, just like I was a president, would look for mission-driven medical stuff. I mean, physicians are the moral compass of a health system. When you introduce a crop of faith-based, humble, well-trained, mission-driven physicians into a health system, the whole standard for a health system goes up.
It's transformed.
And so we evaluate, are they compassionate? Are they hardworking? Are they teachable? Are they people, men and women of good character? And I think physicians, PAs, nurse practitioners need to be evaluating the administrative partners they will be working with. Are they compassionate? Are they hardworking? Are they teachable? Are they humble? Are they men and women of good character? Would I want to entrust my livelihood and my ministry to them? And so you can evaluate that. And if they can't state very clearly what motivates them, meaning the CEOs or the administrators, don't work with them. Give them what's called the heebie-jeebie test. If they give you the heebie-jeebies, don't work with them. Because just like we would say, if a doctor gives us the heebie-jeebies, I wouldn't want them doing a pap smear on our Sunday school teacher. No. So we just say no, and we wait and find the right one. And so I think it's really important that medical providers know very clearly their mission, vision, and values. And they evaluate the mission, vision, and core values of the health system that will employ them. And then analyze, is there a match here? Does that make sense?
Yes. And then what about this APGAR? You equated this a score system to the
Yes.
health. What about that?
Yeah, so there's a guy named Dr. Dave Schmitz at the University of North Dakota School of Medicine. He, as in Department of Family Medicine, used the newborn APGAR framework 15 years ago to develop what was called the Community APGAR score, which is 50 criteria and 5 categories that measure or determine a community and organization's readiness to recruit and retain medical staff when in the community. It's been expanded into nursing and administration and other areas, but it basically it's a way you could do some qualitative interviews, but the answers are, I mean, the questions are always the same. You interview local medical staff, say, what is it like to live and work here under these criteria, and you develop a score that determines the organization's readiness. And we've actually taken that further and used a biblical soil analogy, which is if if a new physician is like a seedling, into what are we planting him or her? Is it rocky, sandy, yucky stuff? Is it fertile? Is it somewhere in between? But what's in the soil? Because you can often tell the condition of the soil by looking at the condition of what's growing in it. And if it's wilted, if it's struggling, if it's failing to thrive, it may not just be the weather. It may be something deeper than that. And so what we did was we cross-analyzed that data through the Community APGAR framework into what the United States Department of Agriculture calls the 4 principles of soil health, which were literally developed after the Dust Bowl in the Great Depression, which came about. The Dust Bowl came about because urban farmers, I'm sorry, European farmers came and were working the ground in rural America, and they didn't know about the wind coming, and so they left the ground exposed in between harvests, and that led to just dirt, nutritious dirt flying everywhere and nearly killing people, or in some cases killing people. And so it was a horrible situation. And so what the United States Department of Agriculture did was they said, all right, the 4 principles to prevent this from ever happening again are maximize living roots, all right, minimize disturbance, maximize biodiversity, and maximize soil cover. So maximize living roots translated to people is take care of your existing people. Make sure they don't leave. Make sure they're healthy. Minimize disturbance. Address the gnarly stuff that's running people off. Okay? It's the stuff that's bothersome and dysfunctional. Third is maximize biodiversity. Simple. Remove bio. What's the organization's holistic view on diversity? Not only race or gender, but look at the whole picture. And is this an organization that invites differing opinions or perspectives or healthy conflict, or does the leadership represent the front line? Does the front line represent the community? And do we invite that diversity within the organization? And then lastly, it's soil cover, maximize soil cover, which is keeping something on the ground in between harvests. It's the innovation in between the high times, because we go through highs and lows. We go through 6 seasons and healthy seasons, and there's going to be fluctuations in volume within a health system, and we got to make sure that we're prepared for the long haul with innovation between ours. So we looked at that data and we said, okay, we have what we need now to address. And so in our case, in Hutchinson, Kansas, we did this 2.5 years ago. Bad news is most of the issues had to do with hospital administration. The good news was most of the issues have to do with hospital administration. We could do something about that.
Mm-hmm.
We could fix the nursing workforce stuff. We can fix the call schedules and the quality problems that are leading to moral injury. We can fix those things easier than we can fix schools or housing access in the community, or that we don't have entertainment in town, or those types of things. We can fix those things. And as we address them, even before they were all fixed, just proof that we were addressing them, the floodgates opened and we started getting more applicants than we could hire here in the community. Does that
So
make sense?
yes, but I'm just wondering, how does a budding surgical resident getting ready to finish and start practice, or primary care, OB, name the specialty, nurses, how do they get that data? How do they find out the facts about a particular community that's, vigorously recruiting them to come?
It starts, well, first of all, a surgery resident or any resident that's coming out, they are in the driver's seat. So the first thing I would do is say, would you mind coming to see me? You want to interview me, you want to recruit me. Instead of simply summoning me to your community, would you mind coming to see where I practice? I can't get away very easily while I'm in training, but I'll invite you to Oklahoma City or to Detroit or wherever I'm training. Come see me. Yeah, that's not really what we do. Okay. That tells me something about you.
Mhm.
Rarely in my career have we ever recruited a doctor without first going to them.
Wow.
We go
Wow.
to them because it sets the tone for a relationship that we're equal here, we're partners. You're worth traveling to, you're worth coming to. And often, um, to her credit, my wife comes along. Kayla comes along and we sit down with them, and 80% of our conversation doesn't have anything to do with medicine. It's why did you get into medicine to begin with? Who are you? Where where are you from? What motivates you? And in the Christian context, what tell me about your faith story. Brought you to the Lord. I mean, and we don't ask those questions in an interview context in any way that's outside the boundaries of HR. We generally just start with, here's our story. Here's what motivates us. And then we don't have to ask. They just share. Oh, you're willing to be vulnerable. You're willing to share your story. Here's ours. And almost always, or always, I would even say, using a superlative on purpose, they'll share if they know there's genuine interest, and there's no intention to discriminate or anything like that. So we're really careful about adhering to HR standards and things like that. But when we go to them, we just ask questions about what does thriving outside of work look like for you? What are your dreams for your kids? Or if you're not wanting to have kids, if you're single, what are your dreams as a single person? What do you feel called to do? And as we do that, it solidifies a relationship. And then when they're coming, it's like a homecoming. It's not a traditional interview. It's like, I can't wait to get there and see what you're about.
Yeah.
We start there. So I would say to a surgery resident, start with the invitation to come and see you. And then you can ask, what's your mission? What's your vision? What's your core values? And if it's some paragraph from a lawyer in the 1980s, they haven't looked at it in a while, red flag. And I would also say, beware of the wells. What I mean by wells is to say, how often will I be on call? Well, or what's the compensation structure? Is it equitable across all the physicians? Well, there's this guy who's been here a while, and no. Beware of the wells. And if there's not clarity, clear is kind. If there's not clarity around that, beware of
Mhm.
what happens
Wow.
there.
Well,
And so I think you can ask those questions.
some really good advice. And I just wonder, because I've never heard of a CEO traveling to meet a prospective young new staff. Does your board or do those on your team, VPs and chief officers, do they ever give you grief that that's not the best way to invest your time as CEO?
I don't think the board does. I think the outcomes speak for themselves. I think they do, acknowledge that my time is limited, and I think there's an appreciation for that. And I can't go every time. Sometimes it's others that go. But the other thing that we do is we summon folks here in large groups where the local chamber of commerce will sponsor a weekend where we fly in 24 residents in for a weekend, just to imagine what it would be like to practice with their friends and near their friends. And so I don't always have to go there, but we can bring them here in large groups too, and just host things for them in the community that are very family focused and personal. And so that's a way of getting folks engaged too. But when you have more candidates wanting to come to a rural area, in an area that's traditionally very difficult to recruit, we don't generally criticize the method.
Uh-huh.
Just grateful for the
Well,
outcome.
you called me the other day with another CEO. You were looking for an OBGYN and wanting to know what connections we might have from our replacement services. And it caused me to remember that in this article from March about these fragile economies in rural hospitals, that the first specialty to go often is OBGYN, followed by the surgeons. Why is that, Ben? Why is it OBGYN so tough to maintain, and then it's the first to go, and then the dominoes start falling?
I think it's the call burden is where it starts. OB in a rural community, even in a city of 40,000, is hard to maintain because if you're on call 1 in 3, that's 10 days a month that you're shackled to the health system. And any more than a week a month, it's very difficult. And so we are redesigning our system here where we'll end up with 4 OBGYNs and 6 or 7 full scope family doctors and some midwives so that OB may be on call 1 week a month, but their backup call for fellowship trained, surgically trained FPOBs and midwives. And so the bulk of the the deliveries are covered by trained full scope family physicians in collaboration with OBGYNs. And then there's a maternal fetal medicine specialist that's from an hour away that has really solidified that collaborative where they're all rowing in the same direction. So we're actually looking for two OBGYNs to join two others that would eliminate our need for any locums coverage. It's sort of the last of the locums coverage in our health system. But two more mission-driven OBGYNs that would want to work in collaboration with surgically trained family physicians that came out of unopposed programs and fellowships, and would really solidify a team that will deliver about ultimately 700 or 800 babies a year here and serve as a regional hub for women's health. But women's health, because of the call burden, OBGYNs are the first to go, because it's hard to maintain it in an OBGYN only model, which is why we're focusing on family medicine and others. Same with surgery. 1 in 3 call is really hard. This fall, we'll have 4 general surgeons here. But ultimately, when we'll retire, we go back to 3, and that's 10 days of call a month. That's a lot to ask of a doctor. And so we really want to go 4 deep in as many specialties as we can.
I remember when we first met, Ben, you told me about your first experience with CMDA. I think it was at Ridgecrest, North Carolina, at a national convention, and you got there and just said, wow, I can't believe this environment, this group exists. And then fast forward a few years, and you, together with Greg Neal, Warren White, and Scott Dooley and others, were saying we've got to have a group of Christian healthcare executives working together and thinking missionally and having discussions. So talk to us a little bit about this effort to bring together, collaborate, communicate between Christian healthcare execs.
Yeah, I noticed, I vividly remember who was speaking. There was a guy named Os Guinness that was there. Another guy named Dr. Thompson was there. It was part of the Pan-American surgeon group in Africa. I vividly remember the talks there. I could still recite their key points. So impactful for me. And I also remember being the only CEO in that whole audience, thinking, where's the miss here? Like, all I knew was Todd Stevens and we can work together. And Todd encouraged me to go to that conference, and I got so much out of it. And I thought, where are my people? Like where's the tribe here? And that led, visionaries like Greg Neal and others to kick off this Christian Healthcare Executive Collaborative. And I think the most effective recruitment tool to grow that small but mighty group right now are physicians. Your membership, CMDA membership, going to administrators they know and trust who likely feel isolated as believers in this industry, saying, hey, I got a group you can be part of. You want to come? And even easier so than administrators recruiting each other, because physicians are so powerful. And when a physician asks an administrator to do something and they have that rapport or relationship, administrator is likely to do it.
Yeah.
They'll say, hey, man, you invite me into something, I'll go. That's a connection point for you and I. And I know if a physician asks me to do something, I'm listening. And so I think there's an opportunity to really grow that, and the medical staff can drive it as they drive so many other good things in healthcare.
And right now, I'm aware that the initiative that Greg and Warren and Scott and others are focused on is so many mission-sending agencies, short and long-term, understand how desperate the need is for effective administration in these mission hospitals around the world, and somehow coming on support. And so everybody agrees it's just getting a consortium, a group of organizations to work together to figure out how are we going to pull this off? How are we going to have experienced teachers? The International CMDA body realizes how important this is and has started a diploma course. So I'm very excited. For any of those listening, as Ben has just said, have colleagues who are strong Christians, faithful believers in their churches and communities that would be interested in such an effort. Just reach out to check. You can get our website and find the check section, as well as the email to get a hold of Greg or Warren or others. And as Ben, you've just shared how the impact of you in that first visit to Karanda Hospital and how that changed your life. I just want to encourage others listening, whether or not they're healthcare executives, to consider such an experience.
Absolutely. I endorse what you're saying. I think it's so important that we develop that skill set. And I'm encouraged to see more and more of that at global missions conferences as well. And just a recognition that, I have a good friend of mine who was a general surgeon in Somaliland. It was part of a residency there, and I knew him since residency here in the United States before he went to teach there, and he was there until and through COVID. And he said practicing in the United States as a surgeon is like being handed the keys to a vehicle, and every once in a while you got to stop for gas. Practicing medicine in Somaliland is being handed a junkyard and being told, build the vehicle. Oh, but by the way, we already need to go. So we better be moving forward while you're building the vehicle and you're running around and you're looking for this piece and that part and trying to put things together. And everyone in the gas station is where's the gas station, right? And trying to figure out how to design all this. He said, when I was in the US, I put out my right hand and someone put a scalpel in it. And here I'm digging through boxes in the bottom of a supply closet looking for one more clean scalpel because I've got a patient dying in trauma. And we need administrators that can run supply chains, and we need administrators that can manage the finances, and we need administrators that can manage the team and ensure that nurses and CRNAs and others are scheduled on time. And he said, I took that for granted until I got here. And I just believe so much that we need these systems in place and these leaders to do these things. And so Check is really about strengthening that capacity. And I just believe so much that there's opportunity there.
Well, Ben, I want to thank you for joining me today on Faith in Healthcare. Hey, if someone has heard something that you shared just really resonates with them, or they maybe have felt a little bit of a call to do rural healthcare, how can they reach out to you and get in touch with you to ask some questions and to introduce themselves to you?
Yeah, so the easiest way is through LinkedIn. That's the only social media I'm connected to, but LinkedIn has profiles and we can message each other. That's the easiest way. Or my email also is ceo@hutchregional.com, which is HUTCH regional.com. And I check those emails. I can't get to every single one every day, but I do check every one of them. And so LinkedIn being first, and then email ceo@hutchregional.com. I'd be happy to connect with folks. And it's important that we stay in this mission together.
Well, and also receive greetings as we close from a good friend who directs our Medical Education International efforts, who's also herself and her husband rural docs, who had that great win that you were talking about early on. Their daughter is coming to join them as a family physician in Hiawatha, Kansas. Dr. Julie Roses, yes. So I
saw her daughter yesterday at an international potluck here in Hutchinson. She came and spent time with us. So yeah, the Roses are wonderful people.
God bless you, Ben Anderson, together with your wife, Kayla, your 4 kids, and your work for the kingdom there in your hospital system.
Thank you for your leadership, Dr. Chubb.
As Ben reminded us today, rural healthcare isn't simply about hospitals or healthcare systems. It's about people. It's about faithfully serving communities that are often overlooked and ensuring that those who are most vulnerable have access to compassionate, Christ-centered care. When healthcare professionals lead with a heart to serve, they reflect the love of Christ to their patients, to their colleagues, and the communities that they're in. And whether God is calling you to rural medicine, to healthcare leadership, or simply to be faithful right where He's placed you, remember that God often does His greatest work in the places that the world overlooks. If you're a Christian healthcare executive, consider learning more about CMDA's Christian Healthcare Executive Collaborative, or CHEC for short, and you can find all about that specialty section by going to cmda.org/CHEC, C-H-E-C. This incredible community seeks to connect and engage Christian healthcare leaders with one another as a source of encouragement and counsel. And if you found our conversation encouraging, please share it with a fellow healthcare professional who needs to hear it today, and subscribe so that you don't miss future episodes of Faith in Healthcare. Next week, friends, I'm excited to be joined by 2 guests that I have known perhaps better than almost any other colleague in my career. Longtime medical missionaries, Dr. Russ White and Dr. Carol Spears from Tenwick Hospital in Kenya, where my wife Pam and I had the privilege of serving for close to 2 decades. Together, we're going to discuss how God is using a world-class cardiothoracic surgery center to bring both physical healing and the hope of the gospel to patients from all across East Africa. You don't want to miss it. I want to thank you for listening to Faith in Healthcare, where our promise to you as a listener, or better yet, a subscriber to this podcast, whether you're a healthcare professional or a patient who loves Jesus Christ, is this: we will do everything that we can to help keep your faith and healthcare connected. We'll see you next time, Lord willing.